All right, let's dive into a really high-stakes medical question, one that affects hundreds of thousands of people, very often our elderly loved ones, every single year.
So, picture this. Someone you care about falls and breaks their hip. They're in the hospital, and the doctor comes in to talk about surgery. And they ask, do you want general anesthesia, where we put them completely to sleep, or regional anesthesia, like a spinal, where they're numbed from the waist down? For an older, maybe frail patient, this choice feels huge. It's not just a small detail. It could affect everything from their recovery to their mental clarity and maybe even their survival. So let's get into it.
First up, let's just make sure we're all on the same page. On one hand, you've got general anesthesia, or GA. Think of this as being put into a medically induced coma. You're completely unconscious, you don't feel a thing, and a machine is breathing for you. On the other hand, there's regional anesthesia, or RA. For a hip fracture, this almost always means a spinal block. This numbs up a huge area of your body, basically everything from the waist down. You might be awake or just slightly sleepy, but you're breathing on your own and you won't feel any pain from the surgery. So two totally different ways to go. But the big question is, which one is safer?
And we really can't overstate how important this is. The patients we're talking about are often elderly, they have other health issues, they're frail. A hip fracture is a massive, life-changing event. The path taken in that operating room can have huge ripple effects, making this decision one of the most critical they'll face.
So what's the answer? Which one is better? Well, get ready for a major plot twist. After literally decades of research comparing these two techniques head-to-head for the big, scary outcomes that everyone worries about most, there's no clear winner. That's right, neither one has ever been definitively proven to be safer than the other.
So how did we end up at this stalemate? Well, for years and years, the scientific community has been locked in this debate. And study after study, as you're about to see, has painted a fascinatingly consistent and kind of frustrating picture. And this slide really shows you the two pillars of evidence that built this consensus. You've got a massive 2016 Cochrane review, that's kind of the gold standard for evidence, which looked at 31 different trials. They checked everything from death rates to pneumonia. Their conclusion? No significant difference. Then, more recently, the big 2021 Araga trial specifically honed in on post-op confusion, or delirium. And, you guessed it, they found nothing. No difference. With evidence this strong, it really looked like the case was closed.
But just when you think the science is settled, something new comes along and shakes everything up. This is where the story gets really interesting. A different kind of study, looking at a huge real-world database, suddenly challenged that whole stalemate.
So here's where things get a little more complicated. A huge study in 2024 did something different. Instead of a controlled experiment, they just looked at the real-world medical records of over 40,000 patients. And what they found was that spinal anesthesia was linked to lower rates of death and major complications. So wait, why the different results? Well, it gets at a classic scientific debate. What tells a truer story? A clean, controlled lab experiment or messy, massive real-world data? This study kept that debate burning hot.
All this conflict, it just forces you to ask a totally different question. If the choice between putting someone to sleep or numbing them isn't the whole story, then what have we been missing?
11,085. This number represents the patients in a landmark study out of the UK that basically changed everything. Researchers in what was called the ASAP-2 trial decided to look past the type of anesthesia and instead zoom in on how it was actually being managed in the operating room moment by moment.
And what they found was just remarkable. The single biggest thing linked to bad outcomes wasn't whether the patient got general or spinal anesthesia. Nope. It was whether their blood pressure dropped too low during the surgery. Look at this. The risk of death climbed right alongside how much the blood pressure fell. This finding completely reframed the entire problem. The real enemy wasn't the specific drug, but the physiological state of the patient.
And this one sentence from the UK's national guidelines just captures that new thinking perfectly. The careful delivery of anesthesia may be of greater importance than the type of anesthesia delivered. It's not just what you use, it's how you use it. The focus is completely shifted from the specific drug to the scale of the delivery.
Okay, so if the big choice, general versus spinal, is basically a wash for those major life-or-death outcomes, where do regional techniques really shine? Well, the answer is in getting way more specific with how we control pain.
Instead of that shotgun approach of a spinal that numbs half your body, doctors can now use ultrasound to guide what I like to call pain snipers. These are peripheral nerve blocks, or PNBs, and they let the anesthesiologist target only the specific nerves that are screaming pain signals from that broken hip. It's truly precision medicine, but for pain.
And man, there is a whole arsenal of these techniques now. Don't worry about trying to memorize all these acronyms. Just think of this as a highly specialized toolkit. Each one of these blocks represents a slightly different angle, a unique way to target the specific nerves around the hip to provide tailored, powerful pain relief. And this is where it gets really sophisticated. A huge analysis coming out in 2025 looked at 87 different trials. And you know what it found? That using combinations of these blocks is the most effective strategy. So it's not just one pain sniper, it's a coordinated team. Certain combos were amazing at cutting down the need for morphine, while others were champs at lowering pain scores after surgery. This is a massive piece of what we call enhanced recovery, which is all about getting patients feeling better and moving faster with fewer powerful opioids.
Now, for a little bit of nuance here, we do have to remember that context is everything. A 2022 review, for instance, looked at one of these blocks, the QLB, and pointed out something important. While, yeah, it did lower pain scores on paper, the difference might not have been big enough for every single patient to really feel that difference in a meaningful way. It's a great reminder that statistically significant and clinically important aren't always the same thing.
So after all that, what's the big takeaway? Where do we stand? Well, that old, simple question of general versus spinal is pretty much being thrown out. It's being replaced by a much smarter, more modern playbook.
The new strategy is super clear, and it really comes down to 3 steps. Step 1, the absolute #1 priority, stabilize blood pressure. Avoid those dangerous drops no matter what. Step 2, tailor the main anesthetic. There's no single best answer for everyone, so the choice is customized to the patient. And step 3, target the pain after surgery with those amazing opioid-sparing peripheral nerve blocks.
And this whole journey really leaves us with a fascinating final thought. We're moving so far away from a one-size-fits-all approach. The future of anesthesia for an injury like this, it seems, isn't about choosing between option A or option B anymore. It's about an expert creating a personalized cocktail of care, stabilizing your body, tailoring the main anesthetic, and precisely targeting your pain, all designed specifically and uniquely for you.